Good morning. I'm Dr. Meredith Warner of Warner Orthopedics and Wellness, and this is our monthly webinar. Today, I'm bringing it back to one of the original talks, plantar fasciitis. This is a new and updated talk, and it's just a few things you probably don't know about plantar fasciitis, along with the basics that you may or may not know, but kind of giving you more of a more nuanced perspective of this very common issue of which you hear a lot and which I think a lot of people think they know about, meaning providers, but don't really. Okay, so I am a practicing orthopedic surgeon, foot and ankle fellowship trained, so I do all foot and ankle services along with regular orthopedic services, so kind of the best of both worlds, I guess, and I'm in Baton Rouge, Louisiana. Sorry, that was my team. So I have two nurse practitioners who are very well trained in both orthopedic and podiatry services, and we provide what I think of as exceptional, really one-on-one, personal, precision medical care. So plantar fasciitis, you've heard this term over and over again, but really, what is it? Who gets it? Why do they get it? What are the outcomes of treatments? What are those treatments? And then what should you do to hopefully prevent it if you don't have it, or if you do have it, kind of self-treat to try to stay away from people dressed in outfits like this. So it's known to be the most common cause of chronic heel pain in adults mostly. When I say chronic, I mean, if you step on a shard of glass and you happen to step on your heel on the glass, of course, that's going to cause heel pain, but that's acute heel pain. Like if you get a bullet or gunshot wound to your heel, that's acute pain. You fall and break your heel bone, you have a calcaneus fracture, that's acute pain, sudden trauma. We're not talking about that kind of pain or those kind of problems. We're talking about that naggy, achy pain that kind of starts for no reason and is just there plaguing your life and doesn't really go away. That's chronic heel pain. Plantar fasciitis is thought to be the most common cause of that. So it's a pretty big scope of problem here, and this red arrow is pointing to some of the damaged fascial tissues within an electron micrograph of plantar fascia. 9% of all foot-based running injuries are thought to be due to this condition, and the lifetime risk of getting this condition is about 10%. 15% of all cases of foot pain that present to an office of some sort, urgent care, doctor, hospital, whatever, are thought due to plantar fascia. That means that's the diagnosis that was attached to that medical record. Doesn't mean it's the true diagnosis, doesn't mean it's right, but that's what is thought at the time. So about 2 million people a year are treated for plantar fasciitis, and the economic burden is about 200 to 375 million or so, the real range 192 to 376. Now, that is a rounding error for some tech companies, but for medical issues, it's kind of a big deal. Where's my water? Okay, so what is plantar fasciitis? Plantar just means bottom of, so the undersurface of the foot. So like this is palmar in my hand, palmar dorsal. In the foot, it's plantar and dorsal. So the bottom of the foot is plantar, the top of the foot is dorsal. Just like the dolphins have a dorsal fin and sharks have a dorsal fin that's on their back. So the top of the foot is actually considered the back, if you will. So that's dorsal. The bottom is plantar. So we say plantar. Fasciitis is, of course, the Latin way to describe an inflamed fascia. Fascia being just thin, long, flat bands of connective tissue that provide support and structure. Now, orthopedic surgery is really the art and medicine of treating connective tissue problems. We think of extremities and spine, so joints, muscles, tendons, ligaments, etc. Podiatry is just simply a later offshoot of orthopedic surgery. So foot and ankle care is really care of the connective tissue of the foot. So the fascia is very important. That is the number one structural element of the foot, along with the Achilles tendon. So fasciitis means inflammation of said fascia. And if you look in this bottom picture of the foot there where it says PF, that is the plantar fascia. It's the first superficial layer of the foot. So you go through skin and a little bit of fat and you're going to hit the plantar fascia right away. And it kind of encompasses the whole bottom of the foot, even though most people, when they think of plantar fasciitis, think of just that little inferior medial portion of the heel bone, which is lit up on the picture to the right, which is where it usually hurts when it is quote unquote inflamed. And we're going to talk about that. Excuse me. Okay. Sorry, my picture cut off that word. Too bad I'm not a professional slide maker. All right. So I put a picture of these toes here to show you what acute inflammation really looks like. So real itis, real fasciitis would look like this. It would be red, it would be swollen, it would be hot, it would be massively painful to touch, and it would blanch. And that is those 4 cardinal signs of inflammation, which we've talked about before. So rubor, calor, dolor, and 2 more. So swelling, redness, heat, pain. Yes, it is pain on the bottom of the foot, so the plantar is appropriate, but it is not really inflammation as this is depicted. It's not really acute inflammation, but it is chronic low-grade inflammation. And if you watch any of what the talks I've given or ascribe to anything that I believe, you know that I believe the fundamental sources of most lifestyle diseases and most orthopedic conditions is chronic low-grade inflammation, oxidative stress to the tissues. That is exactly what's happening, and it's been proven in histology studies of the plantar fascia. What is histology? This is when you send a specimen to the lab, they slice it up into microscopically thin little slices, put it under a microscope and look at it, and can actually see what cells are doing at that particular time whenever that sample was taken. So histology slides of plantar fasciitis support chronic inflammation, not acute inflammation. So that means it can't be from injury, so to speak, because acute inflammation is injury-derived or pathogen-derived. So acute inflammation has some endothelial contraction, like the blood vessels shrink up initially, and then they expand later to bring blood to the area to heal it. There's some cytoskeletal reorganization, like at the microscopic level of the way the organelles relate to each other. There's certain ways they begin to change those relationships that go with acute inflammation. There's leukocyte injury. What is a leukocyte? It's just a white blood cell. And then the cells are crossing into areas of the tissue where they're not supposed to be. And there are a lot of what are called neutrophils, which is the #1 white blood cell that shows up with acute inflammation. So for instance, if we think you have an infected total knee, we'll take some fluid out and we'll count the number of neutrophils. And if it's over 90%, yes, you have an infected total knee. If it's not, you don't. Things like that. And then, of course, massive amounts of swelling. So this picture of acute inflammation is not what we see in plantar fasciitis. Rather, we see chronic inflammation, which is really just a whole bunch of macrophages, yet a different type of white blood cell, and plasma cells, and fibroblasts, and fibrocytes and lymphocytes. So all these different white blood cells that come through, but they're not neutrophils. It just got darker. Like that, like one of the lights went out. And then there's no significant edema, meaning there is a little bit of swelling, but it's not massive swelling as previously. And then there's no significant amount of neutrophils. So yes, you have white blood cells, but they're not the right type of white blood cells to be associated with pathogen or injury-induced acute inflammation. Rather, this is the inflammation that shows up with chronic low-grade irritation, chronic signaling from cytokines and other proteins and molecules that tell the body, yes, attack that tissue, but we don't really know what we're attacking and we don't really know why, but yes, keep attacking that tissue. That's what's going on with diabetes, cancer, Alzheimer's, chronic kidney disease. All of these chronic lifestyle manifestations of our current lifestyles show up as this, chronic low-grade inflammation, and that's what's happening in the plantar fascia when this pain occurs. So the anatomy, just really quickly, you can see on the right slide next to the anatomic specimen slide, you can kind of appreciate there's some distinct bands of tissue. Now, where that little strip of red is, that is the abductor hallucis muscle belly. That goes to the big toe. So that's the inside part of the foot, like where you think of as your arch. There's a thin strip of fascia on the outside, so you actually have a very thin piece of lateral fascia. But the plantar fascia we're talking about that you see in the anatomic specimen slide where it says PF is that thick central band, okay? That is where most people end up developing pain and irritation, and usually where it attaches to the heel bone. So the tissue is resembling, at the microscopic level again, tendon and ligament, so it is connective tissue. It has an inelastic extracellular matrix, meaning there's not a lot of the protein elastin in it, so it doesn't really give and come back and give and come back like a spring. And then there's collagen fibers that are in a wavy or crimped pattern, okay? So they're starting out very crimped, so they will give a little bit, but they don't seem to have that springy, boing, boing, like a slinky toy, you know, dropping down the stairs. It doesn't have that property. A progressive degeneration of this extracellular matrix, so when the protein structure of sort of the fluid around the collagen bundle starts to break down, that is when we start to see that chronic low-grade inflammation on the slides that indicates the fasciitis, but it's that chronic fasciitis. So basically, you have a really pretty, crimped, nice connective tissue with the beautiful extracellular matrix that is there to be functional to provide tensile support to the whole body, really. And then as this problem develops and progresses, that all degenerates, becomes gloppy, and the architecture and the pattern kind of goes away. So that's what's really going on. So most causes of pain, or what we think of as causes, or what has traditionally been thought of as causes, seem to be related to tightness of the structures in the foot, either the fascia, like the plantar fascia, or the different little ligaments and muscles. And when I say muscles, I'm thinking of the core foot muscles, the intrinsic muscles of the foot. So there are multiple small muscles in your foot that you probably don't even know that you have, that are extremely important in terms of balance, function, and also in keeping the shape of the foot, and also in transmitting force from your core and your legs to the foot and the toes. So the foot core muscles are very, very important. And a lot of times these will get contracted, weak, fibrotic. They don't work right. Some people will tell me that they actually contract on their own and they'll get like toe spasm and the foot is really, really painful, almost like a Charlie horse. Plantar fascia usually affects one foot, but 30% of the time it's both. And so to me, that kind of speaks to a lack of true understanding of why the foot is having pain to begin with, because for both fascial tissues to have some type of acute inflammation or itis at the same time, that doesn't make a lot of mechanistic sense. Like what could really cause that for someone, unless it was a systemic problem or some type of anatomic or congenital problem that somebody was born with. So if 1 out of 3 times it's both legs, to me that means there's maybe other things going on. So we already talked about the main central band, which you saw in the other picture. This is actually an anatomic specimen where it's been dissected out and separated from the rest of the structures in the foot. And the big thick band on the inside or the arch side of the foot has 3 separate bands, a medial, central, lateral, and then there's a far lateral band that kind of wraps around the outside part of the foot. So each strip displays creep with loading. What does that mean? Creep is a principle we learn in orthopedic surgery. When you're trying to stretch a tissue, if you apply a constant isometric stretch to it, eventually some of the fibers will give up and plastically deform, meaning they will just relax to the point where they have broached or breached the point where they could spring back to their normal position, and they stay in that lengthened position. So that's creep. You apply enough force to plastically, meaning permanently, deform the tissue. So as you increasingly load this, you get more and more creep to the point where it may be at the point where it's fully deformed and or breaks. The fascia in the plantar fascia is anisotropic, meaning that it'll change its ability to withstand force as the force is applied. So as you load this fascia more and more and more, it should become stiffer and less able to handle that creep. So that's by design, right? As you load it more, it becomes stiffer so that it can support more load. That works until it doesn't. It works until you've hit that plastic deformation point and it just breaks. The medial and central portions seem to have less of this ability to handle creep than the lateral does. So and that makes sense because the outside part of your foot is supposed to be more flexible and able to handle things, different loading rates, different velocities, different surfaces, as opposed to the medial side. The medial side, or the inside part of your foot where the arch is, that's meant to be more structural and more of a force transmitter. So it should be stiffer and it should not deform as much.
A couple people just saying good morning, Simone and Kathy.
Oh, good morning, Simone and Kathy. Okay, I put these in. These are electron micrographs of the plantar fascia just to show you. On the left side, if you can see it, there's the lateral side, the central and the medial, and you can see these nice organized bands of tissue together, and then you have that wavy crimped pattern we were talking about. That is what kind of will give out a little bit as the load is applied. And the top slide on the right is just cross sections. And then again, you have lateral, central, and medial on the right side that show you different levels of organization of these fibers. But that's at the level of like less than a nanometer. It's micrometers. Maybe I'm getting that backwards. But to the point where like you need an electron micrograph or microscope to look at this. Like you're never going to see this with your naked eye or with a microscope for that matter. But it is pretty awesome how well organized these protein collagen bundles are to form these larger organized structures on the bottom of your foot. So I think of the plantar fascia as a triangle, not a right triangle, more like an isosceles, I guess, with the apex at the hypotenuse being at the heel, and then there's a big toe, and then there's a fifth toe. So it's like a tripod. So heel, big toe, fifth toe, plantar fascia connecting them, okay? And then the inside part, think of that like your hypotenuse triangle. That is your strongest bit of the plantar fascia. And then that, if you had a thin, wide, let's say, let's think of it like a piece of steel or some kind of thin, flexible metal, and you took it and you twisted it, you know that if you twist here, the other side's going to respond to that and so on and so forth. And then if you have different tensile forces on either side of the triangle, it's going to respond differently. And that's how it behaves in the bottom of the foot. So you have this really thin, flexible, strong protein structure with three main attachment points. We're going to talk about the other attachment points too. That responds differently to load, and load meaning body weight, and also as you're walking forward or backwards or side to side or whatever. So the main attachment point's the heel bone, thus why most people say they have a stone bruise when they feel this in the heel. Horizontal bands fan forward to form the triangle. And then at the big toe and the small toe, mostly the big toe, there are big vertical attachments. So it's going horizontal, 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 and then all of a sudden it goes up and attaches to the structures above it. So, and there are multiple attachment points, but the main one's at the big toe, and that's important, and we're going to talk about why later. Where they attach on all the toes is also called the plantar plate. You may have heard that Joe Burrow, our favorite quarterback down here, just had turf toe. What is that? It's an injury to the plantar plate under the big toe, which is one of the attachment points of the plantar fascia. So when the big toe hyperextends very quickly, it rips all those structures to include the attachment point of the plantar fascia, and that is a so-called turf toe.
Karen has a question. Good morning. Can I watch on YouTube? No, not live, but we do post them after.
Somebody wants to know if we can watch this on YouTube, and no, we don't have it live on YouTube at this point, but we do post the talks later on WarnerOrthopedics.com and also thewelltheory.com. And on their YouTube channels. So we do have YouTube channels, but not alive. We don't have that sort of a system. We need venture capital backing for that. Okay. All right. Think of this like a passive tension band. So I like this diagram because the pink or I guess that's pink, line is your plantar fascia. And then you have your foot bones. So calcaneus on the left, talus, and then various foot bones until you get to the toe bones. And the plantar fascia is connecting all of this. And you can see as the plantar fascia goes forward, that kind of like angled up area under the end of the big toe, that's your plantar plate attachment. And then it goes forward further and kind of has some more vertical attachments to the flexor tendons. But the main attachment point is there at the metatarsal head, meaning the joint of the big toe bone. Now, as the big toe bone lifts up, okay, as it bends up, which, you know, at what point are you doing that really in your life? Like pulling your toes up at any given point? But think of it like this, when you're standing and walking, you are doing that, right? Every time you take a step forward, you are hyperextending your big toe as your heel goes up and your body weight passes over the foot. So picture that bottom part of the picture, just invert it 90 degrees, and that's you walking or standing in heels. When the big toe bends up, it is going to pull on that strong attachment on the plantar plate and wind it up. What does that do? It applies tension to the plantar fascia at the heel. And so you have a lot more tension through the plantar fascia itself. And also, because you have shortened the plantar fascia because you've wound it up at the big toe, what happens to the foot? Well, the foot has to go like this. So it helps to support the arch. So it's actually very, very, very well designed. When you walk forward and you bend at the big toe, it automatically increases your arch height, shortens the foot, makes it a bit stiffer, and makes it a much more efficient way to transmit the forces from the Achilles tendon and your body weight to the foot to allow you to propulse yourself forward. All of this is very, very tightly regulated and controlled and coordinated and important, which is one of the reasons I don't really believe in the concept of the plantar fascia surgery, which really is just to cut that. It doesn't make any sense to me whatsoever, and we're going to talk about that too. So this is often compared to the tie rod of an arch. If any of you are architects out there or know somebody or are interested in it, you can see this is from a church they're restoring, and you've got the nice, beautiful Gothic arches, and there's a keystone at the top of that, of course. But they've put these metal tie rods to apply a force transmitter to help to support that arch. And if you look down here at the diagram of the bridge on the left picture, there's a tie rod. Then you've got the bridge structure, and you see those arrows pointing down. Think of that like your body weight pushing on the bridge, which is your arch. And then the tie rod is your plantar fascia. So the tie rod basically keeps the arch from doing this with load. If you think of your body weight here on the arch, normally it would just go and plop out, right? Which is what happens with a lot of people with very flat feet. But if you have a really nice tie rod here that has a good attachment point at the calcaneus and a good attachment point at the toes, it is not going to let that happen, and you will maintain the integrity of your foot structure. So the plantar fascia is a massively important biomechanical part of your body. So that big toe attachment is often called the wind loss, or it's likened to a wind loss mechanism, which is from a sailboat. So I put this picture to show you a wind loss. It's a way you wrap this, I guess, twine or string or whatever they call it on a sailboat, and one's going to a sail or whatever. You wrap this and you pull it, and as you wind it around that structure, it tightens up and applies tension to the sail or whatever you have it attached to on the other side, an anchor, sail, whatever. That is the wind loss mechanism, okay? You just wind it up and you're able to tighten it. That is what's happening at the big toe attachment point. So as the big toe extends, you're winding it up, and it's the so-called wind loss mechanism of the foot. So it is a dynamic shock absorber, and it's used to transmit forces. So the wind loss mechanism with the plantar fascia act to increase the force of your foot during push-off, so during gait. So gait is heel strike, early flat foot, late flat foot, toe off, and then you're in the air. Walking is one foot's in the air at any given time and one foot's not. Running, you have a point in time where both are in the air, right? But in either case, assuming that you're all heel strike runners, you're going to heel strike, foot flat, toe up or toe off, and push off. That toe off point is when you're engaging the wind loss mechanism. And all the forces of your leg, your core, your trunk are being transmitted to the foot muscles for push off. It doesn't work well unless you have a really good structurally sound plantar fascia. Now, of course, that's simplified. There are still some rotational components too, so it's not all just in this one plane of motion. At the same time that you're heel striking and toeing off, your foot is also twisting ever so slightly. And of course, if you're doing something like playing pickleball or playing football, you might have other loads hitting you, you're pivoting, there's sidestepping, there's a million things going on at any given point, which is why all of the muscles in the foot are so important, and they provide sort of a sense of balance and a way to handle all of those different twisting motions. But generally speaking, think of the plantar fascia as a tie rod with a win-loss mechanism at the big toe that allows tension to be applied, which increases the arch height and gives you a little bit more force and stability as you're using your foot. Now, one thing your physician may have told you if you have this problem, or at least I hope they told you, is that you need to stretch your heel cord. A lot of people wonder why. Why do I need to stretch the back of my leg? What does that have to do with the foot pain I'm having? Well, this is what it has to do with. I put the picture of the calcaneus on the bottom here with two arrows to depict to you the forces being applied from the Achilles tendon, a vertical tensile force, and the plantar fascia, a horizontal tensile force. Both of these major fascial structures are attached on the same bone, and they're giving different vectors of force at about a 90-degree relationship to each other. Meanwhile, of course, there's the twisting moments we're talking about as well, but we're not trying to get that complicated. The anatomic diagram on the bottom is showing you on the left side of the picture, that's the Achilles tendon, almost like you took it and went like this, and you're looking at the back of the heel and you peeled off the Achilles tendon. The slightly salmon color or darker colored structure is the calcaneus. They've peeled off the Achilles tendon, and then sitting in front of it, kind of blurred out, is the plantar fascia. Okay, and then same thing, the hand is holding there. They've pulled off the plantar fascia and Achilles tendon, and they're showing you the bone. The Achilles tendon's hanging down, and the plantar fascia is kind of flapping in the breeze there. And then that right angle picture between shows you the same thing again, but they've removed the bone. So it just shows you the Achilles tendon comes down, attaches the bone. There's smaller kind of connective tissue connections all the way around the bone, and then it's confluent with and becomes a plantar fascia. So if you remove the bone completely, the Achilles tendon is attached to the plantar fascia itself. What does that mean? You have an attachment all the way from the big toe to the back of your skull through what's called the posterior back line. So the win-loss mechanism, the plantar plates we talked about, to the plantar fascia, to the Achilles tendon, up through the leg fascia, up through the lumbosacral fascia, all the way up the spine, to the neck fascia, to the occiput, all connected in one single line of tissue. So stretching your heel cord matters, and that's why, because they are all connected. So what do people complain about when they come see me? Well, first of all, pain. Nobody likes pain, so most people only go see people like me if they're in pain. Stiffness is the other big complaint, particularly in the morning or after long time periods of being still. Prolonged discomfort, that's that chronicity, that chronic pain we were talking about. A lot of people will say, you know, as I move, as I do more, it starts to feel better. And then when I rest for a while, it just comes raging back. And then most people will say it's worse in the morning, after they rest for a while, after they take long car rides, after they sat at their desk for a while, and then sometimes after exercise. But essentially, it is pain on the bottom, inferior, medial part of the heel, meaning the arch side of the heel, so the midline, and then the bottom is usually where people feel it. And they use term like stone bruise is the word that is most often used. You could also call it a Lego bruise if you have Legos around your house, which also hurts. So who gets this problem? Traditionally, we were taught flat foot and overweight. Those are the people that get it. Well, that is just not true at all. The traditional risk factors we were always taught: overweight, older, maybe runners, which of course that doesn't go with any of that, right? or people standing on firm surfaces all day. Oh, it's because of your job or whatever. Turns out none of this is actually true. I think it's just like much in medicine, it's sort of a communication issue. So a lot of times in medicine, and when you're dealing with people 30 to 60 to however many people somebody has to see a day, you sort of develop a shorthand to try to communicate what you're trying to tell them. And this is just one of those shorthands. Oh, you have flat feet and you're overweight. That's why your foot hurts. Not really, but it's so much easier to say that than to go into this whole talk like I'm giving you. So really, this is who gets plantar fasciitis. Humans get plantar fasciitis. So if you're a human, you are at risk of it. I know that doesn't narrow it down very much, but that is the truth. Middle-aged, women, older, men, overweight, thin, normal weight, flat feet, high arches, heavy labor, office workers, runners, not runners, all get it. There is no real significant delineation between any of those groups. So if you are a human and you have made it into your adult years, you are at risk of plantar fasciitis. And the pain is variable. Everybody's different, right? That's why that pain scale that you have been annoyed with every single time you go to the doctor's office, which, by the way, also annoys us, is useless, because your 10 out of 10 probably means something completely different than my 10 out of 10. And this has been shown in many studies. Based on how you were raised, your culture, different things, that pain scale is meaningless. So all we can say is the pain is variable. Some people it hurts a lot, some people it doesn't hurt much. Generally, it's in right where I made that blue explosion. It's on the inferior, meaning bottom, inside, meaning arch side or midline, part of the heel bone. Words that people use is stabbing, stone bruise, aching, first step in the morning. This diagram on the right breaks it up to, and this is from a study where they did a survey of where does your foot hurt. 52% of the pain is central in that region, and then higher percentages around that added up. But some people will feel the plantar fascia pain in the middle of the foot, like in the arch region, and some people will feel it at those plantar plate attachments. So it's not 100% at that heel pain area, but that's where most of the pain is felt by most people. Now, how do we diagnose it? Now, I'm not going to lie, a lot of doctors, if you walk into the office and say, my heel hurts, they don't even tell you to take your shoe off and they say you have plantar fasciitis. I know that happens, but this is how it should be diagnosed. There should be a physical exam. Sometimes we'll get x-rays. A lot of times we'll get x-ray. I get x-rays all the time to check angles of the foot, measure things, look at the architecture of the foot and rule out things like stress fractures. You can get ultrasounds. They may or may not be useful. Some people will get MRIs, again, may or may not be useful. And then the history. So the physical exam and the history to me is the most important, followed by x-rays and then maybe ultrasound or MRI if like you're really trying to figure out what's going on. So it's been always thought of traditionally as a mechanical problem, right? A wear and tear, an acute inflammation. You have injury to your plantar fascia because you've been standing on it too much and you're overweight. That's the traditional thought pattern, correct? So we've always assumed it's wear, tear, and injury, but I've already told you there's no evidence at the microscopic level that it's acute inflammation. There's only evidence of chronic inflammation, so it can't really be wear and tear or injury. And the treatment has always been based on that presumption, which of course makes no sense. Now, there is a misdiagnosis rate. I think it's probably in the 15 to 20% rate at least, meaning that you're told you have plantar fasciitis, but that's not really why you hurt. But because you were told that, first of all, you get an anchor bias, and that's what you begin to believe. Second of all, that's what all the treatment is based on. And if that is not the correct diagnosis, which is at about 1 out of 5 people, then your treatment is not correct either, right? So it's not going to work. So if you're in one of those buckets, or you're one of those unlucky people that have been being treated for plantar fasciitis for, let's say 2 to 3 years, like when people come finally to see me and nothing's worked, probably it's not the right diagnosis would be my assumption. So just forget everything you've learned about who gets this problem, because I already told you that's wrong. Forget that it's an acute injury problem, because we've already proven that's wrong. And assume that all of the treatments, which are based on this mechanical theory of wear and tear and injury, are also wrong, generally speaking, at least for 20% of the people. So true plantar fasciitis should self-limit, meaning 80 to 90% of it can resolve with no intervention, meaning no treatment whatsoever. The problem with that method, although yes, it's the least inconvenient and the cheapest, is that that can go on for 1 to 3 years, meaning you could have 3 years of pain if you allow it to self-limit itself. Treatment, generally, when we think of as a failure of treatment where you're not responding to treatment, is about 6 months to a year. My opinion, that usually means the diagnosis is not quite right. But a lot of doctors, rather than thinking the diagnosis is not right, that is their point where they indicate you for surgery. So the assumption being that the diagnosis is correct, the mechanical treatment of the problem was correct, and the failure means that you are now indicated for surgery. I think probably if you didn't respond within that 6 to 12-month time period, we should look for a different diagnosis first before you subject someone to the surgery for the plantar fascia. But that's not what the literature does. The literature says after 6 months of failure of treatment, you should have surgery. There's never a question of looking for a different diagnosis. What are the different diagnoses it could be? It could be a nerve entrapment. It could be lumbar radiculopathy. It could be a stress fracture. It could be fat pad atrophy. It could be a systemic inflammatory condition like a lupus or a rheumatoid. It could be other nerve conditions. There are a lot of different things that cause heel pain that mimic plantar fasciitis than aren't plantar fasciitis. So true plantar fasciitis, in my opinion, should begin to respond to normal treatments, meaning stretching, physical therapy, different shoe wear, orthotics, whatever. Within 6 to 10 weeks, you should start to notice a pretty decent difference. Nerve entrapment, in my opinion, is way more common than it's been thought and that it's been advertised or than it's been written about. So I see this all the time, people that have failed the traditional treatments for plantar fascia for a year, 2, 3 years. They show up in my office. I do just basic physical exam stuff. We sometimes do a nerve study to confirm, but a lot of times they just have a trapped up medial plantar, lateral plantar, or Baxter's nerve. And these show you those nerves there. So the tibial nerve comes behind the ankle, makes a few branches, and those branch points directly mimic the pain pathways of plantar fascia, which of course makes sense because the only way your brain's going to get input about pain is through the nerves, right? But sometimes it's not the structure near the nerve, it's the nerve itself. And I think that that's one of the main misdiagnoses that is often missed, is nerve entrapment. So Baxter's nerve, named after Dr. Baxter, who's the first one to describe this in the literature, is a small branch. It's the first branch of the lateral plantar nerve, which is a branch of the tibial nerve. It's the first branch of the lateral plantar nerve, and it dives straight off and goes around the heel exactly where the plantar fascia inserts. In fact, it's usually sitting between where the plantar fascia is inserting and the rest of the foot, so kind of like nestled between the plantar fascia and the heel bone. And if that gets trapped up in anything, and oftentimes it's the fascia to that muscle that goes to the big toe that we talked about before, the abductor hallucis muscle belly, if it gets trapped up or caught up in anything, it will directly mimic plantar fascia pain. And this nerve is tiny. It's about 1 millimeter in diameter. So it's very easy to miss. It's very easy to overlook and to not think about. But I think that is one of the main misdiagnosed problems is Baxter's neuritis, Baxter's nerve compression, or a variant of tarsal tunnel. So plantar fibromas, you may have heard of these. Sometimes this is the cause of pain. A plantar fibroma is an abnormal thickening of the plantar fascia. We're not sure why it happens, and we can't really tell you to whom it's going to happen. But it's a thickening of the plantar fascia, almost like a tumor, but not a cancerous tumor. And these things will cause pain with contact. They oftentimes happen in the middle of plantar fascia. So like if you're one of these people, you'll have a bump on your foot, and when something hits it hard, it really bothers you. I can tell you this, that there's really no good surgery for this. I would avoid any surgery for this at all costs because removing the bump destabilizes the plantar fascia, and there's no guarantee that it won't recur. In fact, almost all of them do recur. Sometimes we can inject these things with platelet-rich plasma or steroid or whatever. People have tried everything to try to get these things to shrink down. I use a verapamil-based topical cream to try to use the calcium channel blocker feature that helps collagen thin out. There's different ways to attack this problem, but if you have a plantar fibroma, you should try to avoid surgery if at all possible, because effectively you end up with this massive dissection like I'm showing you here. The plantar fascia is removed, and then what do? We already talked about the importance of the tie rod. So plantar fibromas are a difficult problem, I will grant you. We don't really have a great treatment. In the hand, they have, when you get like a Dupuytren's, you may know somebody that has Dupuytren's syndrome or disease, which is a similar entity, a thickening of the collagen, but it starts to make the fingers curl down. In those cases, you can inject a snake venom, which breaks apart the proteins in the collagens and lets them relax out. But of course, no insurance companies cover that for the foot. So we can't do that in the foot yet unless people are willing to spend thousands of dollars. So right now, all that is provided for in the foot is what you're looking at here, a massive surgery that has very poor outcomes. So I would say if your pain is from plantar fibroma, not plantar fasciitis, really just whatever you can do to avoid the surgery, I would do. This is sort of what should be going on in the doctor's brain when they're talking to you, this algorithm of where they hurt, when they hurt, how long they've hurt, what is the causing the pain, what makes the pain get better, blah, blah, blah. And then you come down with a diagnosis, and then you come up with a treatment protocol. Anything from plantar fasciitis to a plantar wart, to a stress fracture, to a tendonitis, to a Haglund's deformity, which is like a spur on the top of the heel pushing on the Achilles. And then, of course, you have the spurs of the plantar fascia, which we'll talk about, or this nerve on the right. So this is showing you TN is a tibial nerve. It branches to the medial plantar nerve, the lateral, and then the Baxter's nerve is just a thin, tiny little thing going all the way down to right where the plantar fascia is. So what are the typical treatments? And many of you probably have had this or have a friend that have had this. Inserts, different shoes, night splints, injections, of course, medications, and then different diagnostic methods like ultrasound and MRI that we talked about. Theoretically, you should always only have conservative treatment first, and then surgery should be a last resort. And we talked about that. So most physicians or providers will treat you with these conservative, meaning non-surgical methods for about 6 months. And then if you continue to have pain, at that point, they say conservative management failed, therefore must operate, right? And that's the path. So if you're getting to that 6-month, year point, you're still having pain, and you're starting to get on somebody's radar for surgery, maybe take a step back and rethink things and just make sure you have the right diagnosis to begin with. The surgery is not amazing. It's really just snipping the plantar fascia like we talked about, removing the tie rod, which of course will get rid of the tension on the tie rod, but I don't think the long-term benefits of that outweigh the short-term gain of questionable pain relief. What are the treatments? Time. Some people will just say, give it time. Rest. Avoid all activity. You've probably been told that. Probably one of the worst things you can do for the human body is sit still and do nothing. Activity modification, a little bit more reasonable. Medications. Oh, here's a pill. Take this. You won't feel the pain. Injections. Let me put some steroid near your fat pad and your plantar fascia, because that's a great idea. Laser, RFA, meaning radiofrequency ablation. Topaz, which is basically just poking a bunch of holes in your fascia and then applying a little bit of suction. Extracorporeal shockwave therapy, which is just big blasts of ultrasound to pound it. Physical therapy. I actually really love physical therapy for this condition for the reasons I told you about, those deep connections all the way up the posterior back line and the weakness and fibrosis that happens in the intrinsic muscles in the foot. Those reasons, those issues can be handled with physical therapy, and get a lot of people better if it's true plantar fasciitis. Inserts, boots, night splints, avoiding barefoot. Oh, whatever you do, don't be barefoot. Never mind that human evolution, for millions of years, we were barefoot. Don't be barefoot. That can't possibly be good for you. And then surgery. So those are your treatment options. I put this as a summary of your expected costs for this condition over time. So the low end out-of-pocket patient costs are going to be about $150 to $300. That's the low end of treating this. The top end, if you're going to end up with surgery, your total billed cost is going to be like anywhere from $5,000 to $12,000, with the average out-of-pocket cost being about $9,000, because you never just indicated for surgery. First, you have to go through the 6 months of the non-surgical treatment, which is generally going to get somebody about $3,500, and then they'll indicate you for surgery, and then you got to pay for the surgery on top of that, and then all the post-surgical care. So this is not a cheap problem, thus that $300 million expected costs annually to treat plantar fasciitis. So this is bread and butter, right, for foot and ankle people. Let's treat plantar fasciitis all day long. Here's my protocol. And these are the costs that we can expect to bill to people. Now, this is average, of course, over the nation, and this isn't true for everybody, but I just want you to realize, although this is a very common condition, a lot of people poo-poo it, it's a very expensive condition for people that have it. So what is the success of this treatment? So one study that looked at very long-term outcomes of this problem found that 49%, so nearly half of people, still have symptoms 1 to 5 years after the onset of diagnosis and treatment. So the symptoms will last a mean of 725 days, so a little over 2 years, right? With treatment before they disappear, if they do disappear. And the most common treatment applied to all was a steroid injection, which is going to run you at least $300 when you count the office visit and everything else. So if you have a condition where at best with treatment, and I just gave you the costs and the treatment modalities, is a 50% chance, that's effectively a coin flip. So to me, I think we've missed the boat somewhere in this treatment and diagnosis. So remember I told you before, it is thought to be a self-limiting condition with 90 to 95% of people should get better over 1 to 3 years. 5 to 10% of people across the board in the literature and in the textbooks are indicated for surgery for this problem. But I also just told you that 50% of people still have symptoms at 5 years with treatment. So what does this mean? Well, the literature is really, really bad here. There are really no great prospective randomized controlled trials, placebo-controlled, I mean. And I also told you that 15 to 20% of people have a poor diagnosis. And I told you that the treatment strategies are varied and expensive. Well, there's so many different treatment strategies because nobody really knows the best way to treat this, probably because nobody really understands it. So insoles are $400 to $1,500 a pair, okay? Non-steroidal anti-inflammatory drugs, although typically generic and should be covered by your insurance, they're going to give you GI, cardiac, and renal side effects. Weight reduction is always thrown out there, but there's a 95% fail rate of diets. Stretching, again, I told you physical therapy is a good thing to think about, and that attachment of the Achilles to the plantar fascia is important. So stretching the heel cord matters. Physical therapy I love, but this does take time out of people's lives. A lot of people do have copays, and a lot of people nowadays, because the insurance companies are mandated to cover physical therapy, they cover it, but your copay is effectively the entire cost of the visit. So it's a kind of a loophole for the insurance companies to get away with complying with the law, but yet making you pay for everything. So I love physical therapy, but it is a burden for some people based on their plans. Night splints, which basically hold your foot at a 90-degree angle while you're sleeping. I stopped using these years ago because A, they're expensive, and B, they tend to just fall off of people in the middle of the night anyway. So really, what are they doing? And then, of course, injections, which is the go-to for almost everybody. I personally hate steroids. You know this because we've talked about it before. I'm not saying I don't do it. I do it in certain cases for people, but try to avoid it because steroids are known to provide very short-term Band-Aid pain relief and actually induce more recurrences of pain and worse outcomes late. So again, I try to avoid steroids. You should too. But an injection's not cheap, $150 to $500. So you're doing all of this on the right side for this 50% chance you might be better at 5 years on the left side. To me, that's not a great deal. So why do we image? Why do we get x-rays? A lot of people wonder this. So we're just looking for architecture. You can actually, if you look at an x-ray closely, you can see the pitch of the calcaneus off of the floor. You can measure that angle. You can see if there's a big bump up top. You can see if there's a spur on the bottom. You can actually see the microstructure of the bone. If you have a good x-ray tech, you can look for stress fractures. You can look for bone islands. You can look for tumors. You can look for areas of dead bone. You can look at the angle of the joint and see if they're inverted or everted. There's a million things you can look for with an x-ray if you know what you're doing. So it's not just looking for a broken bone. So if your doctor's getting an x-ray, I'm assuming they're doing it for the reason I do it, which is to look for all of this. You can look for obvious abnormalities like fractures, spurring, coalitions, which are abnormal connections between one bone and another. Calcifications, I look for this a lot. So diabetic people, I can actually see the arteries calcified even down to the tiny arteries in the foot, which is kind of a harbinger of badness and things like peripheral arterial disease. So the imaging is important in terms of the diagnostic plan, and it can change your treatment plan. An MRI, why would you get an MRI? Well, I only get an MRI if I'm really worried about a stress fracture or I see something funky on the x-ray that makes me concerned. Otherwise, an MRI is effectively useless, I think, and this has been because studies have shown that there's really no huge difference between people with pain and without pain in the heel in terms of how the plantar fascia looks. Now, if you are a professional athlete and you have sudden acute massive heel pain on the field, you will get an MRI, and in that case, they are looking for an acute rupture or actual rip of the plantar fascia, which does happen. Why does it happen? Because in professional sports and elite sports, those guys get so many steroid injections just to mask the pain and get them back on the field that their tissue gets weakened over time, so they do rupture their plantar fascia. So in that case, an MRI would be somewhat helpful. Now, do we go in and fix it? No. It's the same treatment. So again, does it really change management? No, but it kind of tells you what's going on. In this case, the top and the bottom, you can see the difference in the thickness in the red circle. The top one's almost 5 millimeters thick, and the bottom one's just about 2 millimeters thick. The bottom one is your normal plantar fascia, and the top one is your abnormal one. So if somebody orders an MRI, they should be looking for tears, stress fractures, the thickness of the fascia. Check the fat pad size to see if somebody's lost fat pad over time, looking for cystic changes in the bone, and sometimes even looking for muscle atrophy and fibrosis. So there are reasons to get an MRI. I don't generally do it except in rare occasions for this particular condition. Ultrasound, you may have been one of these people that gets ultrasound now, which is somewhat useful, and you can do it in the office, so it's much more convenient. But again, you're looking at the fat pad size, you're looking at the thickness of the fascia, you can see the shadow of the bone. This is an inverted picture, okay? The top is the bottom of the foot or the skin, and as you go down, you're getting closer to the foot. The dark shadow in the bottom left corner is the bottom of the heel bone. And that kind of, I don't even know what shape that is, fusiform shape with the vertical yellow line in it, that is the plantar fascia as it's attaching to the heel. So you can measure the thickness there. So you're looking for the thickness of the fascia. What do the fibers look like? Are they in line? Are they gloppy and messed up? How's my fat pad looking? You could sometimes even look at the vessels and the nerves. You can look at the tendons in cross section, and then you can press on the fascia and see if it's compressible and elastic. You can be looking at the ultrasound on the heel and engage that wind loss mechanism and see if the fibers tighten up appropriately. So there's things you can do with the ultrasound you can't do with the MRI in terms of dynamic testing, which is nice. And also you can do it in the office. But again, is it really that useful in terms of treatment results? I've already shown you the treatment results, so the answer is no. Soft tissue tolerance, I wanted to just briefly mention this to you. This picture here is a cylindrical plug pulled off of the bottom of the foot, showing the skin and the fat underneath. What you forget about when you get immobilized or when you're non-weight bearing, or what doctors forget about, is not only does the leg get weak and the muscles get thin and you get atrophy, which you guys are all familiar with, but the same thing is happening in the connective tissues. The bone gets weaker, the tendons get weaker, the ligaments get weaker, the skin gets weaker, and the subcutaneous fat gets weaker. So if you've been immobilized for a long time period, do not be surprised when you start using the limb again that you're having weird random sensations on the skin and the muscle in the foot. That is normal. You are developing back your soft tissue tolerance. Your skin and fascia and connective tissues are no longer used to normal loads. So they have to regain all of that. This is why, again, I don't really love to immobilize people unless I absolutely have to, and I don't like to limit weight unless I absolutely have to, because I don't want people to lose their soft tissue tolerance, which they do. So what can you expect if you, God forbid, have this diagnosis? The long-term prognosis, meaning expected outcomes of this condition in a 5 to 15-year follow-up study of about 174 people using ultrasound during this study, pre and post, found that, I'll tell you what they found in a minute. Let me tell more about the characteristics of the study. So they looked at people between 2001 and 2011. There were 269 baseline participants in the beginning of the study, diagnosed with plantar fasciitis based on the history and exam. 2016 follow-up, they went back and asked people, how are you doing? What was your treatment? How are you feeling? Basically re-examined them years later. They did use ultrasound in the beginning and the end. They did check symptoms, and there were many interesting findings in this study, and this was published in 2018. Sorry, my producer got up and left. Hold on. Okay, so the findings after this 15 years of follow-up study, 137 of the 174 had ultrasounds, okay? The follow-up in the study ranged from 9.7 years from the onset of symptoms and 8.9 years from when the study began, meaning that the study began after some people had already started to have pain. What did they find? At the end of this 10 to 15-year follow-up study of this 174 people, 54% did not have pain, 46% had pain. So again, almost a coin flip. And the average number of treatments in this group was 3.8, meaning almost 4 separate different types of treatments. And they were all of those standard treatments that we already talked about. So 10 years, let's say average, because it was 10 to 15 or so, 10-year follow-up, standard treatments, coin flip, whether you still had pain or not. That is astounding. That is what I meant by interesting findings. So the risk of having plantar fasciitis in this study, after 1 year, 80% will still have plantar fasciitis. This is after your diagnosis. After 5 years, again, coin flip, half are going to have pain. After 10 years, 45% will still have the pain. And after 15 years, 44% will still have pain. This is with treatment, up to 4 different treatments. So the long-term outcomes of this problem with the current treatment regimen is not that great, which tells me either they're not diagnosed properly or the treatments aren't that great. The risk of ongoing recurrent pain was higher if you're a woman. We don't really know why. And it's higher if the pain was in both feet. And I think that's because usually if it's both feet, the problem's really the nerve, inflammatory arthritis, something like that. Usually it's not a mechanical, quote unquote, overload and wear and tear in the same way in both feet. So bilateral to me is usually a harbinger of maybe there's a different diagnosis. Being a woman puts you at risk of more pain. But effectively, even if you have 4 different treatments, which I already told you what that's going to cost you and the time involved, you really can flip a coin if you're going to have pain at 10 years or not. What affected these outcomes? What mattered? I kind of just told you the big things, bilateral woman. What did not matter? Didn't matter how much you weighed. Your BMI was irrelevant. Didn't matter if you smoked. Didn't matter how old you were. Didn't matter if you exercised or didn't. Didn't matter if you were a manual laborer or a desk worker. Did not matter from the time of onset of symptoms to when the study started. So even if you had hurt for like 3 months before the study or 3 days before the study, that didn't matter. The thickness of the fascia as seen on ultrasound did not matter. Doesn't matter. Doesn't matter if it's thick. Doesn't matter if it's thin. And the presence of a heel spur on x-ray doesn't matter. Whether you had pain, or I'm sorry, whether you had a heel spur or not, did not matter 10 years later if you were in the pain-free or the painful group. So importantly for you, the ultrasound findings don't matter. The fascia thickness had no impact on outcomes from pain in this study. The presence of the heel spur had no impact on outcome. The fascial thickness was normal, what I told you, that 2 millimeter or so size, in only 24% of the people that did not have pain. So 3 out of 4 had an abnormal fascial thickness. 1 out of 4 had normal. That's in the pain-free group at that 10-year point. 64% of the asymptomatics or pain-free people had a heel spur on follow-up. So more than half of the people without pain had a heel spur. The fat pad thickness was different. slightly. It didn't reach statistical significance, but it was a little bit thinner for the people that got steroid injections versus the people that didn't. That's one of the big problems I see with steroid injections is the thinning of the fat pad, which is irreversible damage. It cannot be fixed once that happens. So I would caution you to avoid injections, and if you have to get them, don't get many of them at all. That was seen differently on ultrasound, but in terms of outcomes from treatment, nothing mattered. And this study did it at the beginning of the study and then again at 10 years later. Didn't matter. So what does this mean? You can expect plantar fasciitis to last about 15 years and it'll come and go, waxes and wanes. It's on and off. Most of our standard treatments seem to fail. Imaging does not really change over time, and the findings on imaging, unless you find those odd things that I spoke about before, like a fracture or whatever, doesn't seem to matter. Steroids can damage your fat pad, and we know over time they can also cause rupture of the fascia. One thing that happened that should not happen is that people with symptoms avoided activity because they were scared they would cause more problems. So this is called kinesiophobia. I really try to educate people about this. You do not want to avoid activity. Early functional recovery is the best treatment for almost all orthopedic problems. And then also that also helps your brain, your heart, the rest of your body, et cetera. So symptomatic people avoided activity. That is not good and not something that I think benefits the human being over time. So the upshot of this really good study, long-term outcome study, kind of confirms what we've led up to in this talk is that most of what you've been taught isn't really true. So you've been taught a certain type of person gets this. We know that's not true. You've been taught my fascia will be thick. That's not true. You've been taught orthotics, night splint, steroid injections will cure it. That's not true. You've been taught that surgery is indicated after 6 months. We know that's not true, nor does the surgery really work that well. So I just want you to think about all this. It's a lot to take in. But even though this is such a massively common, debilitating problem that affects a lot of people in this country, there's really not a lot we know about it. But I'm having surgery. My doctor said I need surgery. Therefore, he must, that must be what I need. When I get better, why else would they indicate for surgery? Really, it's because you failed the normal treatment. So generally speaking, surgeons are taught after 6 months of failure of non-op treatment, now it's time to operate. Whether that's true or not, I don't really know. I don't think it is. There's a retrospective, meaning they just look back. So there's no controls. There's a lot of bias. There's no prospective randomized placebo-controlled thing happening. Basically, one group looked at their past cases. That's what a retrospective case series is. 68 patients with 7-year follow-up. At 7 years, 50% were pain-free. That's how they couched it. Meaning what? 50% still had pain. Again, a coin flip. Endoscopic release study, the scores improve in about 26 of the studies that were analyzed in this particular meta-analysis. And the only thing they really could say about it was that the return to activity was about 5 weeks before the open group, but it was still months. And then one review of endoscopic release said that the evidence, all evidence for endoscopic plantar fascia release is weak. So in all of the literature that I could find on surgical treatment of plantar fasciitis, there is no evidence of long-term advantage of surgery over other treatments. Meaning 10 years later, it's a coin flip if you're still going to have pain or not, when you have this presumed diagnosis with the presumed appropriate treatment methods. This picture is just showing you a percutaneous plantar fascia release, which is really the only way I would ever do it. And that's when you sort of pie crust it and just put a bunch of holes in it to allow it to stretch itself a little bit, but you maintain the integrity of the structure. Normally for plantar fascia surgery on the right side, if you can see the picture, there's a number 3 and there's the blue tape under the fascia. You can see that dark line through it. That is where a snip went. That is the normal treatment. So you actually destabilize the entire plantar fascia structure with the goals of reducing tension at that heel insertion point. But to me, that blows out the whole tie rod structural function of plantar fascia. So I don't really like that. So we are told that there's an 80 to 90% success rate with a partial plantar fasciectomy. It's a great surgery. It's got great outcomes. My patients do great. I don't have any complications. That is what we're generally told. What the truth is there's a very prolonged recovery. It takes 6 months to a year for people, and there's usually a period of immobilization and non-weight bearing. I already told you what that does to soft tissue tolerance. Generally, there are poor outcomes. It's a coin flip. There are worse outcomes from surgery if you had any pre-op steroid injections. We find there are better outcomes in older people, but older people tend to do better in every study for everything because older people handle pain better, we think. All of the improvement in all of these surgery studies happened over many years post-operatively, and a lot of us think that that is because of what's called regression to the mean in medicine, meaning most of life is oscillations. And most times if you get a peak or like a big change or a volatility point, like a lot of pain from something, it's usually going to regress back to your normal state over time. So when you have an intervention and you don't get the benefits of said intervention for a very long period of time, you have to account for the regression to mean. And then remember, there are about 100 different ways to skin this cat, meaning many, many different treatment options, which usually means that we don't really know the best treatment option. And then when those millions of different treatment options fail, we go to a surgery at about the 6-month point, arbitrary, because we think that they failed, but we're not really sure. And then the surgery, I think, is not so good. There is no consensus, in other words, for how to treat this condition over time at time point A, B, C, or D. So next time you go to the doctor and you get told all of this, just remember this. And remember, you know, there's probably A, other diagnoses that should be considered, and B, potentially other treatment options. And then if you are indicated for surgery, just make sure that that's really what you need, is the only point of me telling you all of this. So they actually did a survey of orthopedic surgeons, foot and ankle fellowship trained, so like the ultimate experts of foot and ankle surgical care. This is 84 members of the American Academy of Foot and Ankle Surgeons in leadership positions, okay? They said they prefer non-op management for short-term symptoms of plantar fasciitis. Well, of course, that's what we all prefer, right? Nobody should jump straight to surgery. They were asked, if there are persistent symptoms at 10 years, what would you do? Sadly, 55% of the experts said they would operate, and 23% of them said they would do a partial release. Not one of them said they would look for a different diagnosis. That is crazy. If you've got persistent symptoms of condition at 10 years despite treatment, why wouldn't you at least explore a different diagnosis as an option? And this is the experts of the experts saying this. So this is just the state of the world we're in with plantar fasciitis right now, but I wanted to give you like the true data so you understand maybe this isn't really where we should be. Maybe there's a better way. Now, what happens when you do cut the plantar fascia? We already talked about it. There's your tie rod of the arch. The blue is the arch. There's a line drawing of the tie rod. The P with the arrow down is your load, okay? So if you don't have that tie rod there, the foot is going to collapse. So there's an 8 to 10% complication rate after plantar fascia surgery, and that's what's reported in the literature. Remember, we only get what people put in print. So if somebody doesn't write up their complications, we don't know what they are. This is the reported complication rate in the literature, 8 to 10%. Recurrent pain happens up to 18%. That's 20%, right? Rounded up. Remember I told you at least 20% were misdiagnosed. Lateral column pain in 30% of people after plantar fascia surgery. Why? The tie rod of the arch, the thickest part of which is in the medial part of the foot, is cut and all the weight transfers laterally. Lateral column pain is a big problem, 1 out of 3 people. The quality of the surgical data, meaning the literature, is very low, meaning almost no, if I really don't even think I found one, prospective placebo-controlled randomized trials. Very small sample sizes, no blinding, most of them retrospective, single surgeon or single center experiences, no consistent outcome reporting. So everybody uses a different measuring stick in these studies. And then remember, the total billed cost is easily over $9,000 for this surgery. So you got a 10% complication rate, 30% lateral column pain rate, low quality of data, very expensive surgery. And remember, at 10 years, 50% still hurt. So to me, I think this is probably a last resort. So this picture of a bridge that lost its tie rod kind of shows you what's happening to your foot. You have complete and full collapse when you lose the tie rod. So the red lines on the calf should be parallel to the red lines in the heel bone with stance. when the heel bone starts to deviate towards the fifth toe, you get the too many toes sign from behind, as we say in clinic. That is when the tie rod is not there and the arch has collapsed. So that is just one of the complications that can happen after snipping the tie rod or doing a plantar fasciectomy. So what can you do to avoid this? A, get the right diagnosis. B, even if you get the right diagnosis or you have the wrong diagnosis, either way, try to avoid surgery if you can. I love physical therapy for this as a go-to treatment, particularly because most times it's covered. It does work well, it's safe, and a lot of times you're really good physical therapists, and if you have a good doctor, will notice other problems contributing to your foot dysfunction, starting from the spine to the hips down. So physical therapy can really assess your entire regional situation, I call it, or regional interdependence, and really make you better overall and treat the pain you have. So I love physical therapy. Now, of course, I'm biased, but I did invent a shoe for this, the healing sole, which I'm not really going to talk about much because that wasn't the point of this talk, but that incorporates many of those various treatment methods that we use one after the other in a clinical setting in one device that you can reuse over and over again over that 10-year period where you have pain that comes and goes. So it's a safe, cheap option that I invented because this problem is so ubiquitous and so poorly treated, I think. One thing you can do for yourself in all orthopedic conditions that everybody forgets is eat well, take some good supplements, and try to get some good sleep and control your stress. That gets rid of a ton of pain, believe it or not. Anything you can do to support your connective tissue, strength, flexibility, good diet, reduce inflammation, reduce oxidative stress, sleep so the body can repair itself overnight. All very important. So I find that the people that hurt the most that come into my clinic always have the worst diets and the worst lifestyles in terms of health lifestyles. So home exercise program activities, it should be okay to be barefoot. I never tell people they can't be barefoot unless they have some kind of massive neuropathy and are a risk of some type of ulcer. Humans have only worn shoes for the past 200 to 300 years. This is a picture of one of the, I never pronounce it right, Tarahumara runners in South America. That is the foot of one of these mountain-based running people. The foot will develop its own protective devices like calluses over time. You can be barefoot. You could live your whole life barefoot and be fine. Now, in a cement-filled urban environment, maybe not so much, but the point is the foot is designed to be barefoot. So I don't buy that you have to have big, heavy, bulky, supportive shoes all the time. Flip-flops are going to be okay if they're designed for foot health. Again, back to the healing sole. I designed that because everybody loves flip-flops. They allow you to work your intrinsic muscles of the foot, which most shoes don't let you, which is why we're so deconditioned in the core level of the foot. So flip-flops are great for foot muscle use, for understanding where you are in space, for feeling the floor better, engaging the toes. So if you have a flip-flop that's designed to promote all of that, it's great, thus the healing sole. Barefoot should be great. You should not be allowed to go. You should not be told you aren't allowed to be barefoot. Stretching the heel cord and that whole posterior back line we talked about, massively beneficial, something you can do at home. Working on your foot core strength, something you can do at home. Perineal muscle strength, that's the muscles on the side of the legs, the balance muscles on the outside part of the ankle. How do you strengthen those? Well, you either have to use bands or tape, but really it's a balance muscle. So any activity that works on single leg stance and balance will engage the perineals. Importantly, hip strength and hip range of motion, really important to work on. So these are all things you can do to help prevent foot pain, which we think a lot of it is from plantar fasciitis. And then if you have it, to sort of start the treatment process yourself and maybe avoid all of those treatments that are expensive that may or may not work. This is the kind of one picture of the posterior back muscles. It doesn't really show you that fascial line, but from the head down the neck spine to the diamond fascia of the trap in the back, to the lumbosacral fascia at the hips and low back, to the gluteal muscles, to the hamstrings, to the calf muscles, to the heel cord, to the calcaneus or heel bone, to the plantar fascia, all connected in one line. That's the posterior back line. You have a posterior chain of muscles that engage that too. All of that can be stretched and worked and made better to help prevent and or treat heel pain. Pictures on the right are just showing different ways to engage the foot core muscles, the intrinsic muscles, and try to get your foot core strength better. My physical therapists at my clinic are experts at this. We're awesome at getting people's foot core strength back. Not every physical therapist is. Just make sure when you go see your physical therapist, wherever you are, ask them, are you going to be able to get my foot stronger? And, make sure that they feel confident about that. And then connective tissue health. Everybody wants to ask me all the time, what supplements can I take? What should I take? Well, remember, collagen is just a weaved triple helix of proteins. So it's different amino acids lined up in a string, and then there's 3 strings wound up together. That is collagen. And then the collagen bundles cross-link to the next collagen bundle with other different protein structures. And vitamin C is a cofactor to make those cross-links. Vitamin C, very, very important for connective tissue health, which I put into my connective tissue multi because it's so hugely important, not just to connective tissue health, but also to your immune system, as you know, which, believe it or not, the two are very tightly linked physiologically. So anything that can improve the collagen superstructure, I take glycine, which is every 3rd position in the amino acid sequence of collagen. Glycine is really, really important to your collagen health. Tart cherry extract is from the pigmented outer skin of the tart cherries. Most dark pigmented fruits and vegetables have high levels of antioxidant structures that benefit humans too. So if you can extract that from the fruit so you don't get all the straight fructose and glucose, that is very helpful to reduce oxidative stress and reduce inflammation. The joint health multi I love because it's got turmeric, ginger, PEA, which is palmitoyl ethanolamide, which reduces irritation around the tiny nerve endings. Remember I told you about Baxter's nerve and the medial plantar and the lateral plantar? So if you can reduce irritation around those nerve endings, your brain doesn't get as much of a signal for pain. Hugely important. Everyone in America, I think, should be, with some exceptions, of course. And remember, this is for educational and teaching purposes only. I am not a treating provider. But I put everyone I can on omega-3s, just so important to human health. These are the omega-3 fatty acids, the DHA, the EPA, highly anti-inflammatory, and more importantly, which you don't really think about, when the omega-3s embed themselves into the cell membranes, it makes it more flexible. And when you get that on a macroscopic scale, the whole body becomes more flexible. So omega-3 is very, very important for connective tissue health. And then for some people, I'll add what we call the Mindset Gummy because it's got extra D3, B12, and magnesium. B12 and D3 found on nerve fibers and in connective tissue fibers, very important for overall body health, for DNA creation and correction and protein creation and correction. B12 is a cofactor for all of that. So the Mindset Gummy is another addition to reduce pain from connective tissues. So assuming you have a great diet, which no one's going to get a perfect diet unless you can afford a private chef with your own organic fields and grass-finished meats. The only way to get the micronutrients that you really need to support the connective tissues and the immune system that is always cleaning up and repairing the connective tissue is with supplements. That's what I do. I know how to eat well and I have good sources for food, but I can't get 9 servings of different fruits and vegetables that are organic every day. That's almost impossible in my schedule. And honestly, it's too expensive. And a lot of times you can't even find it around you. Like literally there's probably 4 or 5 vegetables I eat, generally speaking, just because we don't have the variety that we evolved with. So the only other way to add those micronutrients in is supplementing, which is why I'm such a big proponent of it. And these are just pictures of my product, but that's not the point of this product. I mean, the point of this talk. These are important and I want you to know they're there and I make them for you to empower you to be healthier. We know what the treatments are for this condition and how they may or may not benefit you over time and the complications of said treatments and the cost of said treatments. The beauty of a good diet, sleep, stress reduction, and taking really good supplements is that not only are you going to have less pain and feel better, but your brain will be healthier, your heart will be healthier, your arteries will be healthier, your blood pressure should get better. Everything gets better when you're healthier. That is why I try to treat the foundational problems of our orthopedic conditions rather than just picking any given anatomic point in the body and designing some surgery for that. To me, there's a bigger picture, a more global or holistic or universal picture of our health. And really, it all comes down to chronic inflammation, oxidative stress, as we've discussed. So I think if you can get your health right, a lot of these problems go away. And if they don't go away, it's much easier to diagnose them correctly and then design the correct treatment around them. So hopefully this gave you kind of the big picture of what plantar fasciitis is and how what you've been taught and what I've been taught may not be right, and how the outcomes seem to be really just a coin flip no matter what you spend or what you do. Hopefully I've given you some home exercise program, things you can think about. The safest non-surgical treatments, which I think are going to be physical therapy, really. Maybe look for a different diagnosis if you're one of these people with pain outside of that 6 to 10 week range. And then consider things like the healing sole, which is reusable and designed to promote good foot health over time and very cheap, relatively speaking. But number one message, try to avoid surgery. Number two message, try to avoid steroid injections. Number three, try to get a good diet into your life. We have some questions. Put your questions in if you have them.
Is ankle aversion a result of failed tie rod and the cause of pain? What stretches are recommended to ensure proper alignment for stepping without pain?
That was a complicated question, asking about ankle eversion, the tie rod, and what stretches could be used to avoid pain. Not sure where the pain is, but I'm going to assume it's at the site of plantar fascia. Ankle eversion means your ankle is kicking to the outside, meaning the heel bone is kicking to the outside. I'm assuming that's what you're saying, which in turn often cause midfoot pronation or a flat foot. So yes, ankle eversion can put a lot of stress on the plantar fascia. What needs to happen in that case, usually if you have a chronically everted ankle, your perineal or all the lateral structures get contracted and all the medial structures get loose. So anything to stretch the outside structures, like pulling the foot in towards the arch, trying to stand on the outside of the foot, anything to stretch the perineals would help, and anything to strengthen the inside part of the foot. So like toe raises holding a ball between the heels, which forces inversion of the heel while you're using the foot and ankle muscles, is a great home exercise. It's really hard to do. Make sure you've got a good balance system around you. But anything to strengthen the inside, stretch the outside will benefit if you have chronic ankle eversion, is what I would tell my patients.
Could you explain how the healing sole is a good option?
Somebody wanted me to explain how the healing sole is a good option, even though it's a flip-flop. So first of all, it's relatively stiff by design because it has a rocker bottom sole. The rocker bottom sole is the opposite of an arch. So it basically redistributes stress through the foot from heel strike to foot forward. So it takes a lot of mechanical stress off of the bones, ligaments, and tendons, and just gives your body a chance to heal itself a little bit more. It's got an area of lower density right where the plantar fascia inserts versus higher density over here. So it's just a little bit more cushion there, but not everywhere, so that only one strategic spot has cushioning, because stiffness builds up soft tissue tolerance over time, allows the foot muscles to build up over time, and is actually better for the foot. As we know, most of human life has been barefoot, so we were never really meant to be on soft, squishy things. And then it's got just a little low profile arch support that doesn't change your alignment. I'm not trying to change any foot alignment with this. It's just to give a little bit of stress reduction at that region, but yet not push up on the nerves, because that can add to pain. And then some of them have this thing that engages the win-loss mechanism just a teensy tiny bit. Some of the models don't. But all of these work together synergistically, really just to let your foot heal itself. So just reducing a little bit of stress, reducing some contact pressure, and allowing the foot intrinsic muscles to engage and hopefully strengthen over time. And then again, if you have a flip-flop like that with a rocker bottom that's intrinsically stiffer, it's going to provide enough protection and support for the foot that you won't, it's not going to be like walking on a Javiana where, you know, if you hit a thumbtack, it's going to go through and penetrate your foot. And you can't fold it in half like most flip-flops you can, which also is no structure whatsoever. But again, the goal being all of us should be able to walk barefoot. No one should require shoes all the time. That doesn't really make sense unless you have some kind of massive neuropathic condition. Oh, and yeah, the Healing Soul started as a flip-flop because that's what all my patients wanted. They just wanted to wear flip-flops. Now, of course, I'm in the Deep South and we're really close to a lot of beaches. So of course, that's all you want to wear. But we do have boots and shoes like that for people in the northern climates and where it gets a little bit colder.
Are there any other shoes that you recommend, like athletic shoes that give proper support?
Somebody wants to know if there's any other shoes that I recommend, like athletic shoes. Honestly, the number one athletic shoe I recommend the most to people is the Ultra because it's zero drop, which is a little bit more like being barefoot. So a zero drop just means that the heel is not so much thicker and more cushion than the forefoot that there's not that angle of declination from the heel to the toe. So the heel and the toe are at the same height, which is much more like being barefoot. Now, those kind of shoes like the Ultra were designed initially for the barefoot running movement or the toe or midfoot strike people, but it's great for day-to-day use or like easy athletic gear, even if you're not a toe strike runner. The thicker shoes that are really thick at the heel are really designed for heel strike running. When you slam the heel into the ground after both feet are in the air, like we talked about with gait, so that it reduces that massive pressure from hitting the ground with your heel. If you are a true heel strike runner and you're buying athletic shoes for running, you don't want to go straight to a barefoot or a minimally, or I guess a minimalist foot gear. In other words, you don't want to go straight from a regular running shoe to an Ultra or a zero drop because you have to really get conditioned for it over time because you use different calf muscles, different foot muscles, etc. But that's the athletic shoe I mostly recommend. Ultra, ALTRA. That's just one brand. A lot of shoe companies have come out with zero drops. Really just need a good zero drop shoe if general foot health is what you have in mind. But if you are a heel strike runner and you're running, you still need a cushioned regular heel strike running shoe. I don't really ever pick one shoe over the other for people because my theory is if you need a shoe to make your foot feel better, then your foot's probably not quite right. So I try to get the foot healthy and fixed for people so that whatever shoe they wear, it's fine. But generally speaking too, if you have a decent little insert that corrects whatever intrinsic issues you have with your foot, the insert should be doing all the work, not the shoe. So again, I focus more on foot health. If I can't get that perfectly right in a timely fashion, we go to maybe inserts and then start to change shoes. But the shoe is really meant just to keep you protected from the environment. They try to correct foot problems, but think about it. I mean, it's like saying a belt is going to correct what's wrong with your guts. Not really. You really still have to get the foot healthy.
Pam said great supplements, use them daily.
Oh, thank you, Pam. She uses my supplements daily. So do I.
Kathleen asked, can unaddressed plantar evolve into neuropathy?
Somebody asked if unaddressed plantar, I mean, Kathleen, I guess they mean plantar fasciitis. Can that evolve into neuropathy? No, usually, no. Neuropathy is an intrinsic dysfunction of nerves, and that's usually from a systemic problem with nerve health. Plantar fasciitis, if it's true plantar fasciitis, it's going to be just chronic low-grade inflammation of the fascial tissue. Now, the same issue can stem from the chronic low-grade inflammation, meaning you could get plantar fasciitis and other problems with your connective tissue and get a neuropathy, but the fundamental problem is too much inflammation and too much oxidative stress. But just having pain in your heel doesn't really lead to neuropathy.
Sandra said, thank you, Dr. Warner, for your incredible presentation. Quite informative.
Oh, thank you, Sandra. She liked the presentation and thought it was informative. I appreciate that. Oh, yeah, share it. If you know anybody that has this condition, or God forbid is being signed up for surgery, just to give them food for thought.
Anne said the Healing Soul flip-flops are great, have saved me during my bout with PF. Thank you for making it.
Oh, awesome, Anne. Anne said the Healing Soul saved her with her bout of plantar fasciitis. And I am so happy to hear that. And I hope it kept you from having any steroid injections or too many, and God forbid surgery. So that was my whole goal when I made the product and put it out there, was just to really keep people away from this questionable treatment regimen. All right. Well, thank you for spending yet another Saturday morning with me. I really appreciate it. And you guys all have a great weekend.